So if you agree, I go for a very brief welcome for 1 minute, and maybe you also as the host would like to welcome attendees. Then we start with the first panel.
I think if Daniel wants to give a bit of an introduction, I mean, you can also, because I think Daniel did most of the work and not me. So I don't know, Daniel, you want to say a few words?
So right now, 5.
Hello, everyone.
Hello.
So right now, time is 5 p.m. Tehran time and 2:30 p.m. U.S. time, Swiss time, sorry. And
yep.
Professor Muller, with your permission, I just give a very quick introduction and welcome to the attendees and the panelists.
Perfect.
So
please go ahead.
It's a pleasure to hold this webinar, virtual webinar, between the Swiss team and the Tehran team. Swiss team heading with Professor Muller, and the team on the Iran side, Quantitative Mri Imaging and Spectroscopy group. The webinar is focused on the low-grade glioma imaging, image modalities, quantification, and basically role of artificial intelligence to understand the details of this tumor and to correlate the findings of the imaging to pathology and other fundamental biomarkers. So it's a great pleasure for us to have the 3 panels with the professional panelists, one on diagnosis, one on treatment, and the other one is on prognosis. So I asked Professor Muller also to give an opening welcome to us, and then we start with the first panel.
Okay, so thank you very much. Do you hear me well?
Yes.
Yep. Okay, so perfect. So first of all, well, thank you very much for the organization. So I'm really looking forward to the seminar. I would have obviously preferred to really meet in person, but unfortunately, this year has been pretty difficult for the project because I think in-person meetings have become quite hard to organize over a longer distance. So I'm definitely looking forward to the program, and I'm glad that you managed to put together such a nice program for this virtual workshop that we have on glioma. And I'm pretty sure that I will learn a lot. I mean, I'm not a glioma expert, I'm an artificial intelligence expert. So, but I'm
So thank you very much. If that's fine, we start with the first panel. First panel is focused on diagnosis. Panelists are Dr. Nilipu, neuropathologist, Dr. Roland Weiss, neuroradiologist, Dr. Pachi, MR physicist, and Dr. Humayun, AI scientist. So we start with Dr. Nilipu, neuropathologist. would you please open your microphone because we don't.
Hi everyone.
Dr. Nili.
Is Dr. Nilipur going to present?
I can see the slides, but I cannot hear Dr. Nilipur.
Maybe Dr. Nilipur does not have a very decent internet connection. Maybe it's better to turn off the video. Only
So
the
how should we go ahead?
fine.
Will Dr. Nilipur be able to present now, or should we maybe switch to another person? I don't know what you think.
If you agree, we switch to Professor Roland to take advantage of the
I don't
time.
know, how should we go ahead now?
And we look at neuroradiology qualifying. So maybe we.
Okay, so if you want me to jump in, I can jump in at this point. Do you hear me?
Yes, I hear you well.
That's great. So then I think maybe we can postpone the talk about pathology, which is a pity because I would like to have the opinion of the pathologist always first. But thanks for inviting me to this meeting. It's a great pleasure. And my talk will be a bit about the diagnosis of gliomas. And I will put a very strong focus also on machine learning issues. And if it comes to machine learning, then I think for the diagnosis, the most important expectation that we have from these tools is to give us decision support. That means we need to have additional evidence if a tumor is belonging to a certain class, for example, to a diffuse glioma or oligodendroglioma, then still, I think the most important and the most breaking through technology at the moment is the quantification of images. That means, we'll come in the second part, that means that we would like to monitor these tumors longitudinally. Then, of course, and this will be part of the third discussion today, that's the prediction issue. That means we want to understand which phenotypes are represented by imaging classes. But if we go really into real world life scenario, in most parts of the world and also in Europe, I think these 6 sequences are the essentials, are the key. So normally you have T1, T2 flare, T1 contrast, and DWI. And in the majority of the countries, also in Europe, these glioma protocols, they do not extend 60 or they do not extend 30 minutes. Some of them are even short. In Switzerland, sometimes they're a bit longer. But I think the essentials also for the added value that comes from perfusion imaging, and we will hear later about that, and that comes from MR spectroscopy. And they're one of the, I think, most recent advantages is that we can quantify the status of mutated and of wild-type gliomas by detecting 2-hydroxyglutarate. From the machine learning perspective, I think the most important key issues to remember is that we should take into account the appearance, the shape, the localization, and if you use advanced imaging techniques, also the energy metabolism and the vascularization. And for us as clinical neuroradiologists, I don't want to bother you with this very busy slide, but I think the most important question here is, can we separate diffuse gliomas that are either wild type or mutated from the ones that are p19q co-deleted tumors, that means oligodendroglioma and diffuse astrocytoma, and how can imaging help in that decision? If we start at the very basics, then we discriminate the 1p19q co-deleted tumors and the 1p19q intact, the diffuse gliomas, on different visual features. That means we look for localization. There's a predominance for the frontal parietal lobe for the oligodendrogliomas. We look for the margins. They are usually sharper in diffuse gliomas. There are differences in intensity. There are differences in calcification, but there are also differences in the diffusion behavior and in the cerebral blood volume. And I think this is something that can be taken into account. So, for example, here you see the diffuse gliomas. They have these classical sharp margins. They are homogeneous. They are rarely calcified, and they have some temporal and insular predominance. And if we add a bit more to these visual features, then we can also look into the subcompartment of these tumors. For example, for the glioblastomas, it plays an important role how extended the enhancement is, how extended the necrosis is, and how extended the edema is. Not surprisingly, just putting age as one of the features into the algorithm will rapidly improve the discrimination between aggressive and less aggressive tumors. And there's also some predominance for the location that predicts, for example, the IDH1 status, which is more frequently mutated in tumors that are located along the frontal midline. And then, of course, there's a lot of very different features, like the portion of enhancement, the presence of cysts, or of satellite lesions that also discriminates. And you can see this in the upper row. There are two patients in with temporal and with thalamic tumors. Both of them are very aggressive, so they have an IDH wild type. And the left one is a GBM4. The right one is still a grade 2, but having some additional pathological features, this will also turn into a grade 4 tumor with the new classification. And therefore, we should go back to the techniques that can help us. And these techniques come from the most recent developments of artificial intelligence. So on one hand, there's the longitudinal tumor segmentation. On the second, there's looking at these first order statistics and also looking at the visual features that these tumors encompass. And then thirdly, of course, we look at the deep featuring, that means on the higher order statistics that is done by radiomic analysis. And if you dig back a little bit in history, this is from a paper that we had some 6 years ago, then we could show that the segmentation of the tumors into subcompartments is not only feasible, but it also shows a very nice correlation with expert annotations. And there is, some of you are familiar with these international challenges, the Brett's challenge, and these results get better and better from year to year. And it can also be shown that the composition of these tumors ahead of therapy, that means if you have a native tumor in the very beginning, that this discrimination of the contrast enhancing portion and the discrimination of the necrotic portion has a predictive value for the outcome of the patient, irrespective of the therapy that is applied to the patient. So this is a very important point. Then secondly, of course, the segmentation has dramatically improved throughout the last years with the help of deep learning. And meanwhile, we reach the areas under the curve that go up to 0.8 and 0.9. So that means they're as good as human raters. And if you look at these features that I showed you previously, for example, like the calcification, like the sharp versus the blurred borders, and we put this into simple discriminators like support vector machines, then the results of this automated analytics reach, meanwhile, a level that is at the level of neurosurgical and of neuroradiological experience. And moreover, you can use this volumetric analysis also to predict the outcome of the patient. And if you combine clinical information from wet lab, that means from the analysis of histopathology, and you combine imaging, then you reach a very high prediction value. And this can be used not only for the longitudinal follow-up of gliomas, it can also be used for the differentiation between brain metastases and tumors. And what you can see here, that is just a simple algorithm that uses different support vector machines in order to discriminate glioblastomas from metastases. In the upper row, you can see some of these so-called Vasari features. That means these visual features that are based on location and shape and infiltration. And what could be shown in this paper by our group recently is that it's very easy to discriminate glioblastoma from metastasis, but it's rather hard and rather difficult to discriminate different metastases stemming from different tumors from each other. And the main features that play a role is the infiltrating part of the tumors, that's the extension into epiderma, and that are features that are related to laterality. And this has also been shown by different other groups that if you use this visual features, so these Vasari features that describe the morphology and the appearance of a tumor, that they're almost as good as these higher order statistics, this third level statistic that you usually use in radiomics. But if you combine the two methods, so the data that are derived from visual analysis, from morphology and shape, and you add the texture features to them, then you achieve the highest accuracy. And again, so this accuracy is now in a level where it is acceptable at an area under the curve of roughly 0.8 to 0.9. So it's a very promising tool, I think, also to support human decision by enhancing it with these informations that we usually also use in our clinical practice. And unfortunately, the colleague from pathology has not given her presentation ahead of mine, because I wanted to close my talk with a vision. And this vision is that we need to integrate, of course, information that we get from neuroimaging. This is, for example, all these visual, these location-based features that are related to the shape of a tumor, and we should add molecular pathology to that. And if we do that, then we can build risk profiles. And here you can see two different tumors, one with a so-called BRAF fusion. This is a pediatric low aggressive tumor, pilocytic astrocytoma. Also, it looks very dangerous according to age, localization, and this molecular information that we have. We can put a very low risk to this kind of tumor. In the inferior row, you see a tumor that looks rather benign. So this is a pilocytic centroastrocytoma, but it has this mutation. And by having this mutation and by having a more unfavorable location, supratentorial, the risk increases. So that means for the future, the most important things to integrate is having information from neuroradiology by location, by shape and appearance, adding histopathology, and most importantly, adding molecular classifications to propose the risk of a glioma for an individual patient and to end up in personalized medicine. Just to close this pitch, I would like to pose 4 statements over here. The first one is that MRI phenotypes, they can really act as non-invasive surrogates once you attract the distinct features for the determination of the tumor genotypes. There is already a use and a need for decision support by automated image analysis, which is usually done by longitudinal volumetry, which works nicely meanwhile. But there is still a need for this integrated diagnostics, and we need, you as engineers, we as specialists from medicine, from different domains, we need to work closer together as cross-disciplinary units. And of course, we need to integrate, and this is the major challenge at the end, we need to translate these data characterizations into more than one domain. It means we need to go from simple classification and radiomics into radiogenomics, molecular and clinical information. And so I would like to share at the end my vision by this major paper that has been issued in 2015 and this really proposed the kind of interdisciplinarity that we need. That means neuropathologists, neurosurgeons, neuro-oncologists, neuroradiologists, and engineers will build one
special
great
thanks
formation.
To
Thank you.
Professor Weiss for the excellent presentation on the neuroradiological aspects of glioma imaging. Let's switch to Dr. Nilipur for her speech on neuropathological aspects. Dr. Nilipur.
Hello? Can you hear me? Okay, may I start? Thank you for your nice presentation. I'm a neuropathologist working mainly on brain tumors. This is a chance for me to discuss this interesting issue with you all experts in different fields. As you know, and you are already experts, brain MRI has a very important role in diagnosis of brain tumors. But histologic diagnosis has still the main role for confirmation of the correct diagnosis. So still with all these fantastic technology progresses, we need histologic diagnosis these days. But this is not as easy as it looks. And after surgery, somebody may think that you can see the morphology and have a diagnosis. We have three important issues. The first one is the suboptimal tissues or non-representative tissues from the brain tumor. As you said, there are heterogeneous brain tumors usually we are faced with. So the suboptimal or non-representative tissue for the pathologist is the main issue. But we share the clinical and the radiologic data, and so we can make sure that if we have a good specimen or not. After being sure of having a good specimen, still we have some problems. Some morphologic criteria are not perfect to make a good diagnosis still in 2021. And sometimes the morphology is not representative of the biology, and some low-grade looking tumors behave very badly. Next slide, please. So we use all the data clinical and the most important one, radiologic data, to have a correct and multidisciplinary diagnosis. So in a multidisciplinary approach that we have, next slide please, we use all the colleagues involved. We use the clinical presentation, the radiologic finding, molecular diagnosis, the neurosurgeons finding during the surgery, and all these data together make the correct diagnosis. In 2014, some neuropathologists gathered together and they proposed a layered diagnosis, and in this way they can have the better correlation with the clinical performance of the patients. But in 2016, now they proposed the histological and molecular classification combined together. And from 2016, we are obliged to use immunohistochemistry, FISH studies, NGS, and even DNA methylation profile for having correct diagnosis. But nowadays, in 2021, recently, they have a new manuscript about the new classification of the brain tumors, and the role of molecular diagnosis is now more important. We have two terms that you have to be familiar with. One is NOS, which is goes for not otherwise specified. And if we can't do the proper molecular diagnosis, we can use these terms. So from now on, maybe you heard more and more the term of NOS from our labs. The other term is NES, goes for not elsewhere classified, which goes for brain tumors that the molecular diagnosis and the histologic diagnosis don't fit well together. So in these cases, we can use this term of NES. In 2021, we have 4 groups of gliomas, actually infiltrative gliomas. The first one is adult type diffuse glioma. The second one is pediatric type diffuse low-grade glioma, pediatric type diffuse high-grade, and circumscribed astrocytic glioma. This is very important new classification because even with the same morphology, one diffuse glioma is completely different from adult type from pediatric type. So we have to be very careful to gather all the data from the brain tumors that we have. In low-grade glioma, if our project's gonna work on low-grade glioma, we have 2 types of low-grade glioma that I want to emphasize on their differences. One is adult type diffuse glioma, which has 2 main categories, astrocytoma IDH mutant and oligodendroglioma IDH mutant. And these 2 can have special grading in their own group. For example, we can have astrocytoma IDH mutant grade 2, 3, or 4, and oligo grade 2 or 3. So if we are talking about low-grade diffuse glioma, we are talking about astrocytoma grade 2 or oligodendroglioma grade 2. The other type of low-grade glioma are circumscribed astrocytic gliomas. These are different types, as the next presenter nicely said. These are pilocytic astrocytoma, PXA, subependymal giant cell astrocytoma, and they are quite a large heterogeneous group. In adult type diffuse glioma, next slide, please. In adult type diffuse glioma, so we have 2 types of infiltrative tumors, diffuse astrocytoma and oligodendroglioma that we have to focus on. Next slide, please. But even with the same morphology, with different molecular signature, we have different types. So even these days with morphology of astrocytoma grade 3, if we have a specific mutation like CDKN2, we have different diagnoses based on the WHO grade. So these days, the only morphology is not enough for us for having the good diagnosis. Next slide, please. And for having a diagnosis of diffuse glioma, we have a minimal panel of immunohistochemistry that we have to use. This is IDH1, ATRX, P53, and Ki67, which we are obliged to do, and without these markers, we just can have the NOS diagnosis. And the other molecular techniques that we have, they have some limitations. For example, some labs doesn't have the technique at all. Some labs, like us, more or less have the techniques, but some rare antibodies are not available in all the labs, or sampling of the tissue or choosing a right paraffin block of the tissue. These are all the limitations of the molecular testing these days. Here I just, it's not readable, but it's a long list of essential molecular techniques for different glioma. It's only, you can see it's a long list. And finally, I want to emphasize on, if we are using the term of low-grade glioma, we have to be careful that, are we talking about diffuse low-grade glioma versus circumscribed astrocytic low-grade glioma? Next slide, please. That you can see the radiology or MRI is completely different in non-infiltrative low-grade glioma from diffuse low-grade glioma, and they are usually enhancing. That helps us to be sure. And the other issue is diffuse glioma IDH mutant astrocytoma versus oligodendroglioma. I skipped some slides. Maybe the time is enough. We can discuss the
thank you
rest
very
in
much.
the discussion.
Dr. Nilipur, for your excellent speech on neuropathological aspects of glioma tumors. Let us switch to Dr. Fatih, talking about the eye and the role of MR physicists.
Thank you very much. Can you hear me? Okay, thank you. Hi, everyone. This is a pleasure to attend this webinar with all of the panelists and presenters. So I'm going to talk about the role of MR physicists in context of glioma diagnosis. I would like to first echo on the discussions presented by the two previous presenters. There's a need for integrated diagnostics for personalized treatments, and that need has been met by WHO classification, but still radiology is doesn't seem to be a part of that. So integrated diagnosis should be composed of radiology, pathology, genomics, where pathology can be correlated with radiology scans for finding the anatomic origins of the specimens, and genomics can be correlated with pathology and radiology to guide further testing. If there is a discordant finding, integrated diagnostics could help to guide a personalized therapy. So let's say that if there's a finding in genomics that suggests that the tumor is not aggressive, but pathology and radiologists are suggestive that they are an aggressive course of treatment is needed for a tumor, it means that probably the genetic sample has been contaminated with normal tissue, or there was tumor heterogeneity, or something else that has affected this discordant finding. But the therapy or personalized treatment should be guided by a combination of all of these methods. This slide is not showing for some reason. Could I share my own screen?
Why don't you share your own screen?
Yeah, because it's not showing. Okay. Apologies for the inconvenience. Okay. Okay, maybe we should just.
So the slide is now showing. Dr. Tati.
Can you hear me? Okay. Okay. So, yeah, so the classification of WHO in 2016 was based on a combination of radiology, pathology, and genomics, showing that based on the morphology seen on pathology slides, molecular testing should be done if a patient has IDH mutation. It should be further tested for 1p19q co-deletion to determine whether it's an oligodendroglioma or if it's astrocytoma. On radiology, diffuse gliomas also have a phenotype. If a tumor is IDH mutant, it is predominantly hyper-enhancing on T1 post-contrast images. And if 1p19q co-deletion is positive, suggestive of oligodendroglioma, it is usually poorly circumscribed on the FLAIR images and T2 images. And if IDH mutation is there, but 1p19q co-deletion is negative, which is suggestive of astrocytoma, usually there's a mismatch between T2 and T2 FLAIR, and the margins are also circumscribed. And if it could also be suggestive of secondary GBM, which is IDH mutant, you can see a new area of enhancement on the T1 post-contrast image. And if morphology suggests that this should be GBM and IDH testing also suggests that this is a wild-type tumor, usually these tumors are predominantly enhancing on T1 post-contrast, and then further testing for EGFR and MGMT methylation should be done. So the tumors that are MGMT methylated usually appear with a mass-like edema on MRI, and they have nodular enhancement. And if they are MGMT unmethylated, they usually appear with infiltrative edema and thick enhancement. And if EGFR is positive, usually the tumor has a high cerebral blood volume or perfusion, but if it is wild type, usually it has a low CDV. So from left to right, the images that I'm showing have worsening prognosis from oligodendroglioma IDH mutant to GBM IDH wild type and EGFR mutant. You see that the prognosis becomes poorer and poorer. So many of the studies that are being carried out in radiomics or in many other large-scale studies, structural MRI or conventional MRI is being used. So what does conventional MRI offer? If there is an enhancement on T2 and T2 FLAIR, it is suggestive of edema necrosis, which is very useful for locating the anatomy, and but it shows most of the pathologies and lesions, but it cannot distinguish some of them. And if you see some dark region on T1, it means that this should be an edema region. And if it is bright on T1 post-contrast, it is suggestive of T1, an enhancement or a leakage of the tumor and disruption of blood-brain barrier. But of course, conventional MRI has shortcomings. Usually there's a misclassification that is inherent with conventional MRI because it's qualitative imaging, it's not quantitative. 65% sensitivity and 95% specificity has been shown for high-grade gliomas, which is not very accurate. And for low-grade gliomas, almost half of them are correctly classified. And it has been shown that 1/3 of non-enhancing tumors are actually malignant, but based on conventional MRI, it might be interpreted as a low-grade tumor. So what can a physicist add to conventional MRI, specifically contrast-enhanced MRI, is that not a new technique, just do T1 subtraction, which means that subtract pre-contrast T1 weighted from T1 post-contrast. It will show the regions and signify the enhancing tumor region better and differentiate it from the normal tissue. What about non-enhancing tumor? We know that 14 to 45% of high-grade gliomas do not enhance, and more than 80% of low-grade gliomas also do not enhance. So they have non-enhancing tumor. If they do not enhance on the images, it doesn't mean that there is no tumor inside it. It means that conventional MRI falls short of showing that. Even when T2 or T2 flare is being evaluated, we can see that it is sensitive to non-enhancing tumor and edema, but it is not specific. We cannot distinguish the non-enhancing tumor from the edema region or even from the active tumor region. So what can a physicist add? A physicist could set up a protocol for T2 relaxometry or T2 mapping, which can objectively show non-enhancing tumor. It has been shown that non-enhancing tumor has a T2 value between normal tissue and edema. And actually, T2 relaxometry can quantify non-enhancing tumor with 85% of sensitivity and 70% specificity. And this is a study that shows that the non-enhancing tumor which was quantified on the T2 maps is actually, it can be confirmed with MR spectroscopy imaging as well. Now, we know that probably many of the audience here know about diffusion and perfusion MRI. We know that they are very useful for evaluation or comparison of images within institutions that have specific protocol. Diffusion and perfusion MRI are very useful for showing cellular density and neoangiogenesis of the tumors. And it could complement the use of standard imaging, but there are some problems with them as well. Everybody can admit that it is very useful, but they cannot quantify this value. And there's a problem with quantification when we have, or standardization when we have different protocols at different institutions. So what can a physicist add? This is a rather crowded slide, but I just summarize it. Basically, a physicist can adjust consistent parameters across scanners when we have a large or a multi-institutional study. We have to make sure that all of the imaging parameters are actually consistent, and it actually is showing the parameter of interest or the biology characteristic of interest. For diffusion MRI, diffusion timing, the gradient amplitude and B values can be set. Even MR physicists could set up a protocol for intravoxel incoherent motion imaging, which is multi-B value diffusion weighted imaging, that can quantify pure diffusion and microvascular perfusion as well at the same time. For perfusion MRI, again, parameters could be set up to be consistent, whether it is gradient echo, spin echo, dual echo, or single echo. It is very important for a perfusion MRI for the quantification that the contrast leakage is being accounted for, which can be done by adjusting the protocol or using post-processing methods. And finally, the quantification steps, including the integration and deconvolution, should also be optimized. So in general, what can a physicist add in MRI neuroimaging? A physicist can optimize the protocol, can help in interpretation of the data, can do quality control or reality check, and ensure the consistency across vendors, platforms, field strength, and correct for artifacts, implement new techniques, also perform post-processing, feature extraction, visualization, and actually create an integrative collaboration, which can lead to integrated diagnosis, which can lead to personalized medicine. I would just briefly show one of the work that we have done before in line with gliomas. We acquired different imaging scans, including conventional MRI, IVIM, DTI, and perfusion MRI, and we actually performed neuronavigation to select specimens from edema region, tumor core, and normal tissue. And we performed pathology analysis of the samples and try to see which combination of imaging modalities could actually better distinguish these regions from each other. And we found that CBV, which is from perfusion imaging, T2 flare, and mean diffusivity from DTI are the best combination for discriminating.
So a special thanks to Dr. Fatih for her great presentation on the MR physicist's role to image brain tumor glioma. Let us directly switch to Dr. Hassan Humayun, AI specialist, PhD in AI. Please start with the role of AI in
Okay, can you hear me?
So we hear you well.
Okay, good afternoon everyone. First of all, let me thank you for inviting me to this panel. This talk is designed to introduce you to AI and its application on the diagnosis of glioma. In my speech, I will focus on two major issues of AI itself and its application in the diagnosis of glioma. I'm trying to cover these issues in 2 minutes. First, a definition from artificial intelligence. Artificial intelligence is the science of building smart machines capable of performing tasks that typically require human intelligence. One of those tasks that require human intelligence is diagnosis of diseases. Why we are going to use AI for diagnosis of diseases? Because it improving diagnosis accuracy by providing physicians a second opinion. It facilitates development of new biomarkers and expedites clinical processes by early diagnosis. And there are too many reasons that we can lead us to use AI in the diagnosis of disease. Artificial intelligence offers a wide variety of tools, techniques, and algorithms for solving different problems. One of the main categories of these algorithms and models are machine learning algorithms. Machine learning algorithms are themselves categorized into three categories of unsupervised, supervised, and reinforcement learning. Supervised learning is a category that is very useful in the diagnosis of glioma. Supervised learning themselves include multiple techniques, but artificial neural networks are very useful and handy these days, and the accuracy of artificial neural network models surpasses human accuracy in some tasks thanks to deep neural networks as a very good variation of artificial neural networks. Convolutional neural networks are a subfield of deep neural networks which are able to handle image data, and they are very useful for diagnosis of glioma based on MR images. In order to develop a tool for diagnosis of glioma or a diagnosis of any other disease based on MR images, three parties are in order. The first one is data. Data acts as a fuel. If we have the best AI algorithms, unless high quality data, they cannot perform well. Medical experts are another party. To state the clinical need, medical experts tell us whether they want a model to grade the glioma or they want a model to classify glioma based on its genetic mutation. They are also responsible to label the data and confirm that the data have high clinical quality. They also are responsible to validate AI model with clinical perspective, to validate if the models are usable in clinics. And AI experts, as another party, are responsible to select suitable algorithms and customize it for the task at hand, and also train the model. And also they are responsible to validate the AI model to be sure that everything from the data are cached. These techniques are applied in the diagnosis of glioma from two perspectives: glioma grading, classification of genetic mutation in the glioma, and also glioma segmentation or glioma contouring. A question arises from here that what drives us to use AI and MR imaging for fulfilling the above-mentioned applications. The first one is that biopsy as a gold standard is risky. The second reason is that biopsy themselves have some limitations. And the third reason is that manual inspection of MR images is time-consuming, error-prone, and subjective. This is a place where AI can participate and perform the inspection automatically. In these three mentioned applications, there is a common phase. In this phase is description of MR images. Description can be either handy or automated. When we describe images in a hand engineering fashion, a trained person applies some algorithms and extract some numerical features from images, then fit that features into a machine learning model or into an AI model to learn the behavior of that data to produce the needed output. You can see from here that there is a gap between feature extraction step and classification or modeling step. This gap is source of many errors. In order to remedy this problem, we can automate the process of feature extraction thanks to deep learning and convolutional neural network. In convolutional neural networks, the process of feature extraction and classification are performed simultaneously. In fact, the network itself extracts features that is relevant to the task. If we want to grade glioma, the features which are relevant to the grading are extracted. If we want to classify glioma based on its genetic mutation, the features which are relevant to the mutation are extracted. You can see a convolutional neural network architecture for glioma grading with 97% accuracy. In this network, glioma MR is fed to the network and passes through different processing layers, and finally the output will be high-grade glioma or low-grade glioma. Another one of these architectures are used to classify genetic mutation of glioma. IDH mutant and IDH wild types are classified with accuracy of 83% based on these modalities. From these modalities, CBV performs better than the others. This is a place that we can state that artificial intelligence can help to develop new biomarkers. There is a problem with this slide. Let me to share my screen. Okay, no problem. I can switch without slide. Okay, in this slide, okay. Great. Okay, another variation of convolutional neural networks, which is used in the segmentation of glioma, is called U-net with a U shape. The U-net has two paths of contraction and expansion. If we fit the network with multi-parametric MRI from one side, on the other side, the output is a tumor mask. This U-shaped network can simultaneously take care of both context and localization. This means that not only find the tumor area, the affected area, but exact localization is performed by this architecture. To conclude my speech, convolutional neural networks are very advanced AI models that can automatically extract useful features from raw MRI images. They are applicable to glioma grading, glioma mutation classification, and glioma segmentation. Convolutional neural networks are able to handle multi-parametric MR data. This means that we can feed the network with multiple modalities and simultaneously information are extracted from these multi-parametric data to handle the task. Another limitation of convolutional neural network is that they need huge amounts of quality data to be trained and generalized. Thanks for your attention.
Dr. Humayun, thank you so much for your presentation on the high aspect method to help us differentiate such tumors based on the imaging data. So thanks all the panelists, great discussions and talks from 4 different aspects. The problem of diagnosis of glioma tumors is discussed here. This is not the time for question and answer, and also discussion between the panelists, if possible. So we can start with the panelists for questions, and also I urge attendees, please come front and ask questions if you have in the Q and answer box.
Thank you very much, Dr. Saliqirad. I also encourage everyone who has a question, please post them on Q&A panel. I would like to start with some discussions. So I'm going to start with the radiology aspect with Dr. Wiest. Excellent presentation, and it was very insightful. So what do you see in, let me put it this way, which modality do you see on the horizon for glioma imaging in the next few years? Do you have a favorite MRI, contrast, or imaging, or do you have any other imaging modalities that are best suited for glioma imaging?
Yeah, thank you very much for this question. I think we need to separate this a bit, or to stratify it a bit into the questions that we would like to address. I think first you need to be aware that the majority of glioma imaging is still performed with standard sequences. So that means we will have this classical 5 that I presented. And therefore, I think one of the future options is to put really longitudinal quantifications into place as good as possible. That means we need monitoring design. I think this is really crucial. The second thing, and this has been mentioned also by your talk, that is the role of functional imaging. And there we have these 2 or maybe even 3 options. So we can go for either T2 star, we can go for dynamic contrast enhancement. But we can also go, I think, in the future closer to non-contrast perfusion imaging. You mentioned IVIM on one hand, there is ASL on the other hand. But I think this added value that we receive in terms of just understanding what's the promoter status of a glioma, for example, or what's the difference between a therapy-associated effect or a true progression, I think this should not be underestimated. So this is also, I think, among the most relevant topics. But I think the key issue, or the most important thing, is, can we put these tumors into phenotypes by imaging? And I think this is the really challenge. So we can start with the low-hanging fruits. That means we differentiate between the co-deleted and the intact tumors, for example. And this is already done by spectroscopy. I've just briefly touched this, but we meanwhile have integrated hydroxyglutarate spectroscopy into our routine protocols. It's a bit unfair, to be honest, because we do this as an ultra-high field unit with 70, where it's much easier to be done. But I think this is one of the really the future challenges, to get these fingerprints. And to also to mention my colleague from pathology, I think for me the future is to bring in phenotyping based on imaging in combination with in combination with wet molecular phenotyping. That means with these liquid biopsies, they will really play a very, from my point of view, they will play a very important role. And then of course you extend to things like, for example, the test MR techniques with APT and the glucose. In the future, we will see much more metabolic images. That means based on deuterium imaging, but this is still very much into research. I think, to summarize it, metabolic imaging, functional imaging, and longitudinal quantification.
Thank you very much. You actually answered the other question that I had about D2G MR spectroscopy. So it seems like, as you mentioned, so something like T2 star mapping or contrast-based or non-contrast-based perfusion imaging, these are actually, they can be used clinically in most of the scanners, but not all of them. What do you think about clinical utility of 2G MRs? Do you think it is actually anywhere close to being implemented? I would say in clinical practice, as you mentioned, many of these are just in the kind of infancy level and in the research level. But when we want to integrate the imaging with morphological phenotyping using pathology or molecular testing, we would probably need some sequence or some MRI modalities that can be actually used for daily clinical use. So, for example, if a patient comes in, we can, before the surgery happens, we will acquire the images easily and then pass the results or the quantification results to the radiologists and even pathologists for further diagnosis. So what do you think can we achieve clinical application of any of these methods anytime soon? As you also discussed, radiomics analysis is mainly based on conventional MRI, which, as I mentioned, there are many disadvantages. There are many shortcomings for them, and especially if a retrospective data set has its own problems. So I would say that we need these new techniques, but I wonder how we can make them available for clinical use.
So since this was designed as a pitch talk, I have put, sorry if you cannot see me, for some reasons that I do not know, my camera quit and I can't get it running again, but I'm still here. So I think I've only mentioned the positive aspects, of course, but at the very beginning, before we start really to go into radiomics that are generalizable, that means they can be used among different centers, we need to go into standardization of MR protocols. I think this is the very first issue to be addressed. We have started this now in Switzerland by a very simple approach. We used some phantoms, we used some people that traveled from center to center, and we started really simply by reading the quality of the different centers and defining which image quality we would accept as being sufficient and which quality we would accept as being insufficient. And now currently we are working on a unified protocol. So the second step would be that a nationwide white paper, also in your country, would describe not only the minimum requirements, but in the best case, the optimum requirements, how these glioma acquisitions can be done. And there are many things that need to be addressed. There needs to be a clarification which kind of diffusion parameters shall be integrated. Then you should, at the minimum level, you should have at least one sequence, a T1 weighted sequence, and in the best case a T2 or a flare that is high resolution, because we know that the imaging quality and the segmentation quality dramatically improves if you put high resolution images into the analysis. Then, as I mentioned before, there are these differences that are not only based on these localization-based features, but there are also a lot of differences in the texture of the tumors. That means you need something that informs you about if there's a calcification, if there's hemorrhage, and there we should go for T2 star, and still better if available into this SWI, the susceptibility weighted imaging. And I would personally, so something that we do personally, I would always recommend.
Thank you very much. So my next question is directed at Dr. Nilipur. You mentioned the issue with, I can say, multiple testing methods for molecular markers. What would you suggest for kind of harmonization or standardization? As Dr. Wist mentioned, for imaging, that's a necessity. What would you suggest for different testing methods on the pathology side? Because so let's say that we have a cohort of or we are recruiting a cohort of patients in a study, and of course, if it's a large scale study, we cannot recruit all of them at the same center. So basically, the differences in molecular testing methods could affect let's say the AI model that we are going to create, or any other diagnosis that we are going to make. What would you suggest, or what do you think about this? I cannot hear Dr. Nilipur. I don't know if that's just me or. Dr. Nilipur, we cannot hear you. Oh, yes, your voice is coming.
You said, you know, the different applications of different molecular studies in different glioma. May I get it?
So my question is, what do you suggest? What is your take about different testing methods at different centers, especially in a large-scale study, which is multi-institutional? What is your take? How can we harmonize the methods for molecular testing?
Yeah, actually, the major problem is having the technique in all the labs. But we think in this stage, it's not necessary to have all the techniques in all the labs and have them harmonized. Maybe we can limit these techniques in 2-3 specialized labs, and in this fashion we can have more harmonized, you know, molecular techniques. More or less in Iran we have the problem of having available the antibodies or the high techniques, you know, examinations, but at least in this stage in Iran we have 2-3 labs which are offering the acceptable techniques for diagnosis of brain tumors.
And do you have any, I mean, I wonder if you have any statistics about the differences between different molecular testing methods like FISH versus sequencing versus other methods. Do you have any statistics about it, or do you know which one is superior to others?
Actually, we can't say that they are, which one is superior to the others. We have to choose them very carefully for each case. You know, case by case, we have to start with immunohistochemistry. Sometimes the immunohistochemistry is enough, and then we go to FISH studies. Sometimes this is also after immunohistochemical study, FISH is enough. We are not, we don't have to do all the NGS for all the brain tumors, you know. Sometimes we have some data from the less expensive and easier techniques. We don't need to do all these things for all the tumors. And for example, even DNA methylation is not available in all the best centers in Europe, for example. There are some specialized labs which have methylation profile technique. So these are not, we can't say that they are superior together. Sometimes even an easy and simple immunohistochemistry technique can help us to have exact molecular diagnosis based on WHO classification 2021.
Thank you for that. So this kind of brings me to the next question. So I wonder, any testing method has false positive, false negatives. I would say that for IDH mutants, what do you think about well, let's say that the misdiagnosis for these patients? For example, if you use FISH method and you misdiagnose a patient, well, in Iran, I'm not sure if there's any other or alternative course of treatment for people who have, let's say, MGMT methylation or another kind of molecular marker. But in general, would that affect the treatment of the patient?
Actually, we can categorize the tumors based on the clinical data and imaging, the age of the patient. Usually the IDH mutant tumors are from second decade, third decade to fifth decade. They are usually non-enhancing, and on the morphology we can have the other findings than ADH mutation. The IDH1 marker that we use in immunohistochemistry, it can find about 90% of IDH mutations. And usually if we are suspicious for having an IDH mutant tumor and the IDH1 is a negative, we go to FISH, and usually we found the IDH mutation if our suspicion is very high. But we can use other markers together. For example, if I have a diffuse glioma with ATRX mutation and P53 mutation, but my IDH is negative, I'm thinking about false negative in IDH1 or IDH FISH study. So we can bring all the other, data that we have together to have a definite diagnosis.
Thank you very much. And the other question is, how would you select the tissue section for testing a molecular marker? Do you think that sometimes there might be these false negative in specific cases could be a problem with sampling issue? I mean, sampling problem could be first because of biopsy, or second because of the section that the pathologist is selecting for sequencing. What would you suggest to overcome this problem?
Yeah, actually, this is one of our very, important issues, choosing the best paraffin blocks in actually low-grade tumors, because usually the infiltration is not very dense. But usually we took the sample which is more cellular, for example, from sub-PL aggregates or perivascular aggregates from the the secondary spaces of Scherer, that we have more tumor cell aggregates. And for having the not having the false negative results, we usually have either internal control or we have an positive external control. So we use all these things together to be sure that our result is, we are confident about our result.
Thank you very much. And the next question goes to Dr. Homayoun. Artificial intelligence has emerged over the past few years very strongly. Many people are working on radiomics, radiogenomics, and deep learning methods for different tasks like segmentation that you mentioned or classification. But one of the issues that we have, as you mentioned, is that we need quality data. If we don't have quality data, basically we cannot expect that AI model to be generalizable or reproducible, especially in multi-center studies, or specifically because many of the AI methods are based on retrospective data. How would you suggest to optimize the AI methods to ensure generalizability of them, given that we don't always have quality or large cohorts for analysis?
Okay, very good question. In my presentation, I told you that data is, and that in fact data acting as a fuel. If we don't have enough data, then AI models cannot perform well. But in case of small sample size data, we have to perform some tasks like data augmentation. We attempt to learn the distribution of data and then using that distribution to generate some data to increase the volume of data. This is a very straightforward way to attempt to
Thank you very much.
make the model
also,
to
do you
be
think
developed.
that maybe I would say that proper cross-validation, splitting the data into independent test cohort versus training cohort might also be helpful, especially if, I would add to your description that probably we also need to make sure that we have, like pathology, we have internal and external validation in the data set as well. What do you think?
Actually, we evaluate the AI models again by using the data. If we have enough data, we can easily separate data into training sets, validation sets, and testing sets. But in case of lack of data, we have to use validation techniques such as leave-one-out cross-validation. In leave-one-out cross-validation technique, we use a majority of our data to train and a minority of our data to test. By leave-one-out cross-validation or coupled cross-validation, we are using all of our data both in training and testing phases.
Thank you very much. I have one last question, and we don't have much time. So for a deep learning method to work well, I would say that we need standardized pre or post-processing methods to be done for the images. Can you give us some insight about that? So, for example, let's say that we have a cohort of clinical images, and each one has different resolutions, or each one has been acquired with different imaging parameters. So the contrast of the images are different. But there are some post-processing methods that we can apply and try to account for this issue. Do you think that, how much do you think this would, or lack of standardization would affect your AI model?
Okay, first of all, deep learning models are designed to work with raw data, the data without any pre-processing. But the problem is, again, the lack of data. If we have enough data, we can set the deep learning model with raw images. But in case of small data, we have to standardize somehow our data to make the model more generalized. And as a post-processing, we also apply some process to remove false positive and false negative to refine the result.
Okay, thank you very much. Thank you, everyone. I need to wrap up this session because we don't have much time. I really appreciate the great presentations by everyone, and the attendees, please feel free to drop your questions in Q&A. We will try to address them in the next sessions or even through email.
So thank you so much, Dr. Fatih, for moderating the session, and all the panelists for great presentations and discussions. We have 5 minutes for rest, and we will start the next panel, which is for treatment, in 5 minutes at 6:30 Tehran time, and it should be, I believe, 4 Swiss time. See you then. So this panel also has 4 panelists discussing the problem from 4 different aspects. The panel starts with Dr. Jahanbakhshi, a neurosurgeon working on low-grade glioma. We'll continue with Dr. Kazemi, a neuroradiologist working on this problem. And also, I will present what MRI can offer, quantitative MRI, and also basically multi-parametric MRI. And Professor Muller will cover the part we need to know about AI knowledge and techniques for this problem. So the treatment panel on imaging glioma, let us welcome Dr. Jahanbakhshi, the neurosurgeon, to start the panel.
Hi, do you hear me?
You will.
You can
Yes,
hear
we
me?
do.
Okay. Hi, and thank you so much for inviting me for this panel. It is very interesting because we can share our knowledge, and as a neurosurgeon, we put problems and we represent the problems, and sometimes we are ourselves part of the problem for diagnosis and treatment. But it is very good to see your opinions about the new solutions for our problems. Okay, to open up this session, I want to present some challenges that I have routinely confronted with, and I would like to describe common solutions we use and describe their shortcomings, and ask you to help us to solve the problems. Okay? This is a case I had recently. 16 years old girl presented with complex post-traumatic seizures since 4 years ago. On imaging, you can see on the left medial temporal there is a lesion. There is a high intensity into T2 MRI, and and you can see on the left side there is no contrast enhancement for this lesion. So it is very important for us to decide what to do, if it is a tumor or it is a developmental problem, or it is maybe a post-traumatic event in the medial temporal lobe. According to the seizure history and the location of lesion that can define the lesion, define the seizure, we decided to perform surgery. But many times we are confronted with patients with this type of lesions that there is no seizure, there is no symptoms. So it is very important for us to know if it is a glioma or it is a non-important pathology. For example, I had a patient with a similar lesion that was found incidentally, and I decided to follow him, but he referred to another surgeon, and that neurosurgeon decided to resect the lesion, and the pathology was glioblastoma, and that was very strange for me because there was a very little lesion without enhancement, but the pathology showed glioblastoma. That was a very shocking experience for me, that I was missing a glioblastoma. And I had another patient with very similar pathology that we performed epilepsy surgery because of low-grade glioma, and he referred to us after that with a glioblastoma. So this is a challenge to decide if we can follow this lesion, or I have to perform surgery, and after surgery, what should I do? Radiotherapy or something like that. We usually rely on contrast enhanced MRI, but you can see here that in the second example I said, we can miss a glioblastoma case. Okay. This is another patient I have hospitalized recently, and I am going to operate him. You can see a very large lesion in interhemispheric frontal region, and there is a very clear pathology, but there is no enhancement. It can be a low-grade glioma or something like that, but you can see on the right frontal lobe there are high-intensity lesion that we don't know if it is part of the lesion or it is related to the edema that is correlated to the tumor. So it is very difficult for us to decide, at least before operation, to resect just the interhemispheric lesion or extend our resection to the right frontal lobe and to the posterior toward parietal region. So it is very important to us to decide and know which one is edema and which one is tumor. We usually use, for example, perfusion scans. If there is a high perfusion in that region, it can be referred that it is glioma, not edema, or we can use MRS. But frankly speaking, we don't trust this imaging modalities, because there is a large positive, false positive, and false negative results. When I wanted to classify the problems we usually confronted with, I classified them as preoperative, intraoperative, and postoperative challenges. On intraoperative challenges, you can see the brain shift that may ruin our imagination about the place, about the location of tumor, and about the extension of tumor. So we want imaging modalities, and we want artificial intelligence solutions for these problems to solve us the problem of brain shift and the problem we have in intraoperatively. And there is another issue during the operation. It is very difficult sometimes to differentiate between brain tissue, normal brain tissue, and glioma. Sometimes it can be touched. Glioma is a little harder than brain, but sometimes some gliomas are very, very similar to brain tissue in terms of visual characteristics and tactile characteristics. So specifically when brain tissue is contused during the operation, it becomes very, very similar to glioma. So it is very difficult for us to differentiate between brain tissue and glioma. And sometimes we have cases that have performed radiotherapy before operation. In that cases, this differentiation becomes even more difficult. Or for example, this case is a 15-year-old boy. I operated him today. He had operation for posterior fossa glioma, and he had some recurrences. He performed 4 surgeries, and he underwent radiotherapy. And when he presented and referred to us, he had this lesion you can see on the in the MRI with faint contrast enhancement. It could be something related to radiotherapy, or maybe the recurrence of tumor. Actually, we using the available techniques in radiology, you can imagine perfusion scans, we can imagine MR spectroscopy. There is no clear distinction between recurrence and post-radiation changes. There is no definite, and you can draw a clear line between these 2 entities. So this is our problems, that we can use MRS, but we can't trust MRS for decision making. So at first we followed this patient, but I followed him for 3 months because imaging modalities like MRS and perfusion did not a clear distinction between these 2 entities. And after 3 months, the case around the tumor was enlarged, and the patient was clearly deteriorated. So now it was clear that it is tumor and recurrence, so I operated him today. But I think we missed time for 3 months. Okay, so this is a very now unsolved problems that we can trust on perfusion scans and MR spectroscopy to find a clear distinction between two entities. It is another case I had about 3 weeks ago. 64 years old woman presented with confusion and altered consciousness. You can see there is a clear lesion with mark enhancement on the right parietal lobe, and this lesion may be lymphoma or glioma. We decided to perform biopsy for her, and unfortunately the biopsy resulted in was not diagnostic because biopsy just showed inflammation or inflammatory cells, like some inflammatory microglia and something like that. I don't know if I have performed another biopsy lower region or upper region, I could found a better diagnostic biopsy from this lesion. So I wanted you as scientists in radiology and artificial intelligence, we want a way to find a path for biopsy and find a way to show us which biopsy region can be more informative. And it is one of the most common problems we have in everyday practice. For example, this is a woman, this is around 40 years old woman. I operated her for a glioma on right frontal lobe in front of motor cortex. We performed electrocorticography and neuromonitoring intraoperatively, avoiding motor cortex. And you can see there is a small part of the tumor that in neuromonitoring was in favor of motor cortex. So I decided to not resect this region of this part of the tumor. So the problem is not that, but the problem is that on follow-up, I wanted to know exactly when the tumor is rising in size, and is I want to make clear that the tumor has growth, so that I can refer him for radiotherapy or decide another operation. It is very important for us to detect very little changes inside of tumors. In usual practice, we just see this lesion by eyes, and we have to decide and judge if there is a tumor growth or not. But I think artificial intelligence could help us in this matter, and there is some drawbacks. For example, there is some problems. For example, there is very different MRI protocols, it is not possible to perform every MRI with a single protocol and in a single center, and there should be some ways to compare different MRI protocols and deduce the changes in size of tumor. Overall, I want to ask you to help us in decision making, and I want artificial intelligence to replace clinical judgment, because I think clinical judgment may have many drawbacks and may have many errors. Thank you so much.
So thank you, Dr. Jahanbakhshi, for your presentation on this topic. You basically raised questions and needs and pains.
Some back coupling. I think somebody needs to shut the microphone because they have a speaker center.
Yeah. Yes, please turn off your microphone. Thank you. So thanks a lot for, yeah. Thank you, Dr. Moon. So thank you for your basically raising questions, basically your goals and aims and pains and needs for imaging and AI in this topic, basically treatment of glioma tumors. So let us move forward with Dr. Kazemi, neuroradiologist, to see what radiology has to answer some of your questions.
Thank you, Dr. Salide. I don't know if you have my voice or not.
Yeah, you
yes,
will.
pretty good.
Thank you very much. I'm so sorry not to have my slides. I don't know what you call a radiologist without images, but it's a problem that I can't do anything about it. But I know everyone here is familiar with MR images and what we are going to talk about. And I also watched Dr. Jahanbakhshi cases and his real questions about the problems in imaging. And as you know, in this session, we are going to talk about the post-operative and intraoperative imaging, the points that I want to mention in this 10 minutes. First, they talked in the previous session about the preoperative imaging, and the surgeons need neuronavigation during the surgery in intraoperative, and some researches are present that they say DTI imaging and also functional MRI imaging can help the surgeon to delineate the mass much better during surgery if it is done before the intervention. But the point for us starts after surgery. After surgery, even if 2 or 3 or in first 2 or 3 days, there are some questions about if there is any remnant of tumor or not. Maybe it's not routine in some centers, but some centers do it. They say intraoperative neuronavigation can solve this problem in some extent, but if we have imaging in 2 or 3 days after surgery, we can have routine flare imaging as T2 images, and as we all know, and many researchers have cleared that in near all of cases, flare images show much more extensive abnormal area than a normal tumoral tissue. what is recommended in many researches, and we do it, is performing ADC maps by diffusion imaging. In ADC maps, we must do segmentation, and we must have clustering of the tissue. We routinely see three parts in the tumoral tissue as a region with significantly restricted in day 3-2 after surgery. This restricted region is routinely ischemic focus that is usually seen after surgery, and it is not tumoral tissue. If we recognize it segment by segment, we can map it, and also AI and radiomics can help us in this area. The second region is non-involved normal white matter that the ADC shows the appearance as the other parts of brain in this abnormal flare tissue. And the third and important part is the tumoral tissue. Tumoral tissue, as we are talking about low-grade glioma, especially we are focusing because the more problems are in infiltrative astrocytoma, and the parts of tumoral tissue early after surgery shows higher ADC values as 1.4, 1.5, and it is helpful. And in many articles they have shown that it is exactly comparable with follow-up MRI after 3 months after the surgery, and it is compatible with it, because we know that many low-grade glioma, if completely resected, we have a complete tumoral resection. They don't need any adjuvant treatment, and maybe adjuvant treatment in completely resected tumor can make the prognosis worse, and overall survival is better without other intervention. So it's important to have this. Another issue is, as the dear surgeon told us, is follow up the size of the tumor. Yes, after the 3 months, we can have a basic image, and we follow up the patient on that basic image. And the size usually is done by filler. In T2 we have a routinely T2 high area, but in filler centrally low with a rim of high region, a mismatch with filler images. I thought I have the image, and we have the filler images, and we must do the velocity of diameter expansion. Routinely they do velocity of diameter expansion by in routine MRI by mean tumoral dimension and mean tumoral dimension in 3 volumes, but we can do it semi-automatically by measuring in slices, contour the lesion and measure the volume. They have focused on it and have seen that it is comparable with mean tumor diameter, and they have seen the routine low-grade glioma without anaplastic changes show a mean tumoral diameter change about 3 or 4 millimeters per year, but in tumors that grow to anaplastic changes, we have about 8 millimeters change in year. And here really radiomics can be helpful. Another things in follow-up of patients who undergo the treatment, chemotherapy or other new treatments, we know that in the chemotherapy of patients with low-grade glioma, the changes in size are delayed, maybe even for 1 year, and we can't rely on treatment response by the size of the tumor, which can be helpful in this era. Is MR spectroscopy is the best in the chemotherapy patients, and also everyone is familiar with post-RT necrosis. We know that we don't have ADC restriction post-necrosis, but they have many tumoral changes, post-treatment changes that may show restriction, and the best we can do is MR spectroscopy or we measure relative cerebral blood volume by perfusion, by dynamic susceptibility contrast perfusion. They have shown that the numbers more than 2.3, 2.4 are helpful in this era. And I think I speak more about the advanced imaging in prognosis when we are going to talk about the prognosis. Thank you very much.
So thank you so much, Dr. Kazemi, for your explanations on the raised questions by our neurosurgeon. I wish you also had some specific examples as slide presentation, so we could basically locate things more accurately. But I appreciate it, and we will get back to you at the question and answer part. I continue this panel. I basically try to explain quantitative functional MRI, what has been discussed with radiology, and Dr. Fatty as the MR test for brain tumor mapping. I try to introduce some of the tools for basically tumor mapping in terms of tumor grading and tumor contouring. I'm not going to talk about basically surgery planning or biopsy planning. They need other tools. So about the brain tumors and conventional MRI, Dr. Fatty gave a very accurate discussion. Now we all know that conventional MRI major problem is lack of accuracy, lack of specificity, if you like. Anything abnormal and pathological basically shines up in conventional MRI. There are ways basically to help the conventional MRI performance. The Dr. Fatty explained very well. Here I would like to introduce diffusion and perfusion MRI from the basically side of a physicist, MR physicist, with some more details. We know that diffusion MRI basically talks about microstructure, basically biomarkers like extracellular volume fraction, which is defined as cellular volume divided by extracellular volume, is really helpful. Let us look at extracellular volume fraction and the changes of this biomarker in different scenarios. Okay, it basically changed dramatically with cellular density, so it gives us a really molecular and cellular biomarker. So when basically cell density for a tumor changes, a very sensitive marker is defined and basically introduced by diffusion if the images are good quality images. But of course, for the part of specificity, we need to explore a little bit more. For cellular volume also, we have inverse relationship, and we see that when we have larger cellular volume, diffusivity decreases. and also extracellular volume, which has direct relationship. When we have a more larger extracellular volume, we have larger diffusivity. Here, this slide is very educational. Very simple, says ADC increases progressively from dense cellular tumors to necrotic systems. And this thing is quantitative. It means that statistically significant results can be achieved in different parts of a tumor. So basically for tumor type grading, tumor type discrimination, and also tumor contouring, diffusion is a very strong basically tool, and better derivatives of diffusion like diffusion sensor imaging and markers extracted from this modality with basically preferably higher direction imaging can help even better. Again, ADC as a biomarker of tumor grading in primary glioma, the results of WHO on different grading shows that different parts of ADC value are statistically significant results for this discrimination. As you see in one tumor, basically different parts of the tumor are indeed differentiated by diffusion modality in a GBM tumor. So what a physicist can do for us to improve it, Dr. Fakri also mentioned this. The major part of this physicist role is basically to define a very standard diffusion protocol. Today, diffusion protocol is improved in different machines, in Siemens, GE, Philips. We have basically the diffusion MRI in every slice, basically concentrated. So every slice is shimmed well, so the quality of diffusion is improving greatly, and the hope to have better information from diffusion modality is increasing and increasing every day. So the distortions like EPI distortion, multi-shot EPI, and other pulse sequences and the post-processing techniques to remove the artifact are improving greatly. Let's switch the gear to perfusion MRI. I would like to talk about perfusion. We all know that perfusion becomes more when a tumor is growing because of more tumor microvasculature, because tumor needs more blood to grow, and this microvasculature grows, and the perfusion MRI is able to monitor this thing. I'm not going basically to talk about how this technique is being imaged and acquired at this time, not the scope of my talk, but we know that there are different ways to do it based on contrast enhanced, exogenous contrast enhanced, using T2 star weighted imaging, which is DST MRI, and also based on T1 weighted imaging, which is EC MRI. We are able to quantify and to estimate cerebral blood flow, cerebral blood volume, also permeability, and basically what is being permeable from the vessel capillary and basically vessel wall. ASL perfusion in tumor, we are not going to talk about it, but ASL perfusion use basically the blood as the endogenous agent. So this is the main sketch of what has been doing in DST MRI, so I'm just going to skip it. Assuming we have a standardized protocol and image acquisition for perfusion, the analysis part plays even a more important role. Quantification and extraction and estimation of the parameters from two ways of model-based and non-model-based are playing major role, basically to give us biomarkers to understand what's going on in terms of grading and basically tissue characterization and tumor contouring, if you like. So the non-model-based quantification is easier, of course, not as accurate, but when we solve the pharmacokinetic model in the appropriate way, which is not a very straightforward thing to do, as Dr. Fatty mentioned. AIF selection, appropriate AIF selection, solving this inverse problem in the presence of lots of noise and artifacts and motion and stuff like that are basically major challenges. But on the bright side, we see a very statistically strong relationship between cerebral blood volume and tumor grading. This slide shows this fact very well and very clear. This slide also shows cerebral blood volume basically plays a major role to understand the treatment response. So on the top of tumor grading, for the treatment response, we also have different basically levels of cerebral blood volume number. Here, round frontal mixed low-grade glioma is basically has a recurrent situation. So in about
Hello, I think we lost you for a moment.
Hello, I think we lost you for a moment.
I don't have any sound anymore. I can still see the slides.
so sorry, I was disconnected. The Adobe Connect jumped out, so I just basically redid Adobe Connect. So as you see, this relative cerebral blood volume basically jumps with a very much higher number, showing basically a recurrent tumor for right frontal mixed low-grade glioma that is now a recurrent tumor. But again, what a physicist can add to this, here I need to basically discriminate or divide the role of a physicist into two steps. First step is to have the right acquisition. This acquisition is improving in terms of pulse sequences and better hardware offered by the basically vendors very greatly these days. But on the second step, when we need to extract and estimate the appropriate parameters correlated with the tissue type and also tumor grade, a physicist today can do a lot in the research centers or in the clinic as a physicist. But I would like to mention that these roles of diffusion and perfusion are indeed complementary. So we tend to move towards multi-parametric MRI, and of course AI, which will be covered by Professor Muller. I just want to talk about the multi-parametric MRI. One of the very first attempts of multi-parametric MRI in this topic is a diagnostic algorithm when we look at T2 hyperintense mass, and a very great job by Professor Law shows that okay, we indeed are able to basically understand what's going on for a very general T2 hyperintense mass in terms of the tissue type and tissue characterization, simply when we follow the decision tree and we follow the appropriate modality, and not even very complex AI techniques are needed. Of course, this is a very start of this area, but very successful and actually mind-opening. But in the continuation of this paradigm and this idea, we look at this example, discrimination of high grade from low grade neoplasm, and we see that the basically experiment of MR spectroscopy and perfusion give us a great accuracy. Another example as a discrimination of primary from secondary neoplasm in tumor grading, if you like, shows this nice combination of diffusion and perfusion and MR spectroscopy. Again, with basically this accuracy, specific and sensitivity. In two different research projects we did at the Tehran University of Medical Sciences, we tried to tackle the problem of tumor contouring. In the first attempt, we tried to use diffusion, perfusion, and T2 weighted MRI with basically knowledge-based algorithm, very simple algorithm, similar to what Mengla suggested before, and we got some nice basically results out of it, using publishing Magma. But in the next attempt, we had basically most of the imaging modalities we could line up at our clinic, and we also got basically the multi-point biopsy co-registered at the point of pre and post surgery, and basically we extracted many features out of this quantitative modality, and we also showed that T2 ISO T2 basically perfusion MRI, flare and mean diffusivity from DTI are important modalities, and they give us features, especially when we would like to understand where a healthy tissue is discriminated from a non-enhancing tumor, which is very important in tumor contouring for surgeons, and also published in the MRM journal. So I just wrap up my presentation. Quantitative MRI and the approach of multi-parametric MRI are very strong, but we need to know which modality to use in which application very accurately. A lot of research, of course, is needed in every discipline and every disease and every tissue basic characterization. The role of AI will be very important. Professor Muller will discuss it right after this presentation. And again, I would like to emphasize, as Dr. Professor Wick said, this is a great teamwork. Teams must work together, and if we are able to build communities and build teams to work together will be successful, otherwise not. Thank you very much for your attention.
Okay, thank you very much for your presentation. And I will now continue with the artificial intelligence part on the therapy section. I don't have any slides. I will talk a little because currently we've never really worked on glioma images themselves. So I really hope that within this project, this collaborative project, we will be able to obtain these images and to have concrete results in a few weeks or months from now. So first of all, what we have looked into in terms of therapy, using AI for therapy, are two things. One is therapy planning, really looking at, based on quantitative imaging features that we extract from the raw imaging data, how we can decide on the best therapy. And then also therapy monitoring, so the application of identifying if the therapy is successful or not, and how we can actually measure that. So most of what we do is either using standard classical radiomic features. Many of them are texture-based, but some of them are also maybe more stable and are based on, like, I don't know, diameter, volume, average gray levels that are even easier to calculate. One of the difficult parts, I mean, that has come up also in the presentation that we have seen before, is that there's a lot of heterogeneity in the imaging data. MRI has many different weightings, that many different protocol sequences. There are different machines. I mean, you have 1.5, you have 3 Tesla, you have 7 Tesla. I mean, you have a large variety of different imaging approaches. And when we train tools to do prediction, for example, and we have heterogeneous data, it's very difficult to get good results. So quite often, data quality and also the quantity of data that is needed to really train a system and make it generalized to unseen data sets is often high. So getting the data in the right protocols, I mean, that's an important part. So harmonizing protocols and making sure that they're taken with comparable image sequences and that the image sequences are complete, because sometimes we get only a subset of the sequences, and then if we want to compare different images to do prediction, that's often definitely not optimal. And particularly in treatment planning, or if we measure like success of treatments over time, it's quite important to really look at what's the trajectory of patients. So how do things evolve? Is it going up and down? Is there a straight tendency to something? And again, it's difficult to get large data sets, because quite often we have like cross-sectional data sets where we have like 1, sometimes 2 time measurements. But I think it's also really important to develop clinical trials where homogeneous data sets are required and people are followed over a longer period of time. So we also have clinical endpoints. We know about survival times, about, I mean, quality of life, survival, these kind of parts. And I mean, we've seen that radiology imaging has really evolved quite a bit. We've also seen a presentation on histopathology image. So we also have projects on histopathology image analysis. And I think it's really important to also separate the two and see the advantages and inconvenience. When histopathology is on a molecular level, so we do have a very detailed information. On the other hand, if we take small biopsies, we might actually miss the most severe parts of a cancer and then take a decision, maybe not on complete data. Whereas in radiology imaging, we do have the full tumor and that we can analyze. And I think that's quite an important part to take into account for the decision making. Another thing that we can do in radiology imaging is looking at the tumor microenvironment. So not only the tumor itself, but also the tissue around it, because that actually plays an important role in tumor progression, growth, etc. And I mean, there's several research approaches that have shown very good results in actually looking at the tumor environment. So I think that's pretty much what I would like to mention. So I'm really looking forward also to getting more concrete results, getting data also from this project, and then being able to apply the tools that we have. So features either based on classical radiomics, texture analysis, but also features based on deep learning, which is also something that we have worked on quite a bit, in looking at how well they work and how we can combine these approaches to to do predictions and really help clinicians in their decision making. For that, obviously, we would need a much better integration, because most of the research approaches currently are disconnected, are working on retrospective data sets and not prospectively. And I think what's really required is doing a prospective study, following patients, and then also learning about some of the challenges that we're facing that we're maybe not facing when we work purely on retrospective data. Another part that I find important is also how we can explain decisions of deep learning to clinicians so they get actionable knowledge out of the decision. So not just a black box response saying, oh, this is very aggressive, this is not so aggressive, but really looking at a more detailed response with quantitative values that can then be taken into account for treatment planning and treatment decisions. And thank you very much for your attention. Unfortunately, I'm teaching right now straight away, so I need to leave, so I won't be available for the discussion section. But if there are concrete questions also for me, don't hesitate. I mean, you can ask the questions, and I think they can be transmitted. I mean, Daniel can transmit them to me if needed, or the others as well, if there's anything specific for me. So I hope you will have a good discussion and also a continuation of this seminar. So thank you very much.
Thank you, Professor Muller. Thank you very much. I just want to say that with the presence of Dr. Jahanbakhshi as the neurosurgeon, we are hoping to get more data too. Also, there are different centers. We are really trying basically to go and retrieve their data. Some of the centers we are approaching today looks like they have some perfusion, diffusion, DPI stuff. So we are trying also to collect some data from other centers as well. But I think 2 weeks ago I visited Dr. Jahanbakhshi at his hospital, and he's basically cooperating with us to collect more data, the data he has, and also the new patients with our proposed protocol.
That's very good.
On this point, I would like also to have Dr. Jahanbakhshi's comments.
Okay. That's very good. I mean, I'm really looking forward to that, and I think that that would be really a very interesting outcome of this collaborative project. Okay. Thank you very much. Bye bye.
Okay. That was a very good presentation by you. Thank you so much, Dr. Sadiqarad. There was some data that was amazing about differentiation between low grade and high grade. But when do you think we can enter this data into clinical practice as a rule? You know, because everything we see on papers are suggestions, but we don't use them routinely in clinical practice.
I think data, first of all, first things first, we need MR machines with enough quality control. I'm talking from aspect of a physicist. So we need machines with enough quality control, so we need to make sure that, okay, for example, perfusion or MRS we are acquiring is really standard, and basically the data can be easily harmonized. Next thing to have is the appropriate collaboration. You know, the radiologist with the neurosurgeon, the physicist, and the analysis expert with the radiologist. And this cycle must be formed. We are now 3 basically boxes in this Adobe Connect. We must be exactly in the same manner we must be connected together. The radiologist must be connected to you, and I must be connected to the radiologist, and we need to basically complete this chain. And after this part is basically, after this relationship is solidly formed, there is a great hope. And of course, on the top of it, we need good machines. The machine that has, actual QC. We need to be courage enough to basically move forward and question managers of imaging centers if your machine is really QC'd, if your machine does really have the enough standard and enough quality control, can really pass the Academic College of Radiology ACR guidelines and standards. So from the point of view of a physicist, I need two things. One, a good machine, and the other one, the appropriate and correct connection. Radiologist to you and physicist to the radiologist, and this link will work.
Yes, exactly. Another point I should add, I think in some hospitals, such as our hospital, the equipment are one step forward related to an appropriate interpreters. We don't have experienced interpreters in our hospital, but we have perfusion scans. We can do perfusion, we can do MR spectroscopy, but we have problems with a person who is very experienced in brain tumors and can interpret perfusion scans for us. So I think there should be a balance between equipment and the human resources.
Exactly. I think your example is just enough to understand the situation. Assuming you need some help on a very specific tumor, and you have some idea which modality to acquire, but at the same time, you need a linked and connected radiologist to you to give you the appropriate idea, okay, which modality really works. This is not the job of a physicist, this is the job of a radiologist. Okay, which modality we need to acquire at this time. And when this thing is known, okay, then the radiologist's role is basically accomplished. Now the physicist, in combination with the radiotechnologist, must stay together, do the appropriate acquisition, and do the appropriate analysis, and generate numbers and whatever is outcome of the acquisition and analysis. And then the report should be formed in the right way, and then again the report must be forwarded to you. Maybe at this time we need to know the opinions of Dr. Kazim as a radiologist.
Yes, I'm on the same page on you, dear Dr. Sayyarad. I think that, for example, in Imam Hospital, we have tumor boards with head and neck surgeons. We are always communicating with ENT and head and neck surgeons. Also, we have a common round with neurologists. But neurosurgeons, I don't know, they are always busy, they have always patients, and we can't have enough connection. We will be so happy to have connection. And I think the forgotten ring is connection, as you told us and you recommend us. I'm on the, because we must know, but yes, some things are in both everyone knows, but the connection is not. I think the dear doctor is in Rasul Hospital, yes. I think, yes, I know that in that hospital they are not so connected. Even in head and neck radiology, as I know, even I know that they have a powerful team. Also, we wanted to work on Parkinsonism, and everyone told us you must work with Rasul Hospital. But we like it, and we are looking for more communication.
Okay, and I think that artificial intelligence can fill this.
So I also heard basically people attending this webinar to ask questions from the team of surgeons, radiologists, and physicists, if there is any question. Maybe I go ahead and ask a question in line with what we discussed already, because this thing is really important and one of the major shortages of our clinic in Iran. Dr. Downbashi, let us get back to the same example. Assuming you have a complicated case for which you need some help, and you, of course, you have ideas how what to image for this patient, but of course you need better ideas. You need more accurate ideas. So you propose your case to a radiologist, maybe. I'm not sure. How does it work at this time for you? Let us discuss the routine.
I had a short fellowship in Italy, and I observed a very close relationship between neurosurgeons and radiologists, and it was very interesting because they sit around and discuss a patient for the best part of the tumor, for biopsy or everything else. And for example, there was a very straight connection between surgeon and radiologist, and they could ask his opinion or her opinion about the modality they want to order for the patient, and for interpretation of this modality. Another problem that is, I think there is in front of us, it's that our knowledge as neurosurgeon, our knowledge is behind the progression and development of neuroradiology. So, you know, there are many new pulse sequences and many new modalities and modification of older modalities in neuroradiology that we are not aware of. So I think a very specialized or, you know, subspecialty working would help us to fill this gap. For example, a neurosurgeon that is working on glioma should not work on spine pathologies, for example. So there is a lot of information growing every day, and we are not aware of development in new technologies. So besides a very good communication between different disciplines, there should be subspecialty training and subspecialty working to get ready a neurosurgeon to deal with new technologies. So, and another issue that I mentioned before is that artificial intelligence can help us to fill this gap, because no one can learn everything about radiology. So when I want to speak with Dr. Kazemi, there are some issues that I don't aware of, I don't understand. And there are some issues in neurosurgery that a radiologist is not aware of. You know, the patient problems and problems that are there in during the surgery. For example, you know the exact border of, you may know the exact border of tumor and brain tissue in radiology, in an MRI scan or using diffusion weighted images. But when you want to deal with this tumor intraoperatively, you can't see anything, and you can differentiate between the characteristics of the tissues of tumor and normal tissues. So these problems should be dealt with joint work, and I think using artificial intelligence as a
excellent. So maybe we should take this meeting for granted and basically start more closer relationship toward your needs and pains in the clinic, hopefully referred to us as basically technology person and also radiologist who is able to put the appropriate reports on it and start working much closer together. Let us basically discuss same thing with Dr. Kazemi. And you know, Dr. Kazemi, we talked about the efficiency of collaboration in this manner and how the three parts must work together. You as a radiologist have a lot of responsibilities to do, of course. And you said a neurosurgeon is very busy, and I understand they are very busy. But I also work with radiologists. They are also reporting many different cases every day, and their job is really hectic, and sometimes they do not have enough time to invest on one case, or basically sit and discuss it with the physicist and look at the data, look at the fusion and discuss it together. And in many situations they don't even see each other, and they don't even have a common ground to basically share the knowledge and data together. So how do you see this problem of your basically to help, and how do you propose a solution?
Connection between the radiologist and the physicist?
The radiologist and surgeon first. You mentioned the mornings are important. But of course,
Yeah.
not all cases can go to morning, or I'm not sure how you want to basically comment on this. And then our relationship between you and the physicist. So at this time also the radiologist needs to sit with the physicist and discuss details together. And most of the relationship we had up to this point has been in our research proposals, and many of them have been over phones, not just with you, with many radiologists, unfortunately. But these relationships must improve and basically change. So what is your opinion from the two sides?
Yes. Yes, as you know, I'm a head and neck and neuroradiologist. I'm first head and neck and then neuroradiologist because it's on the same page. Yes, I agree with the doctor that we must all work sub-specialized, and I think Tehran University is a rule, and most of the radiologists are working sub-specialized. In head and neck, I say I have weekly tumor boards. When I go there, I recommend them, as the doctor said, your patient needs this sequence. It can help you. We are connecting together, and best of our research is perform when we are talking to each other, and when we listen to each other, and we do brainstorming. Also, I know that we have a problem for connection with our physicists. There are some problems that we must talk more, we must solve it, we must have the respect of our areas, and we really need physicists. I think in every center, when you have a physicist, you are much more successful for doing what you want. Sometimes I want to do something, but I can't do it with a physicist. Yes, I think the professional connection can help us. And I say we have more connection with head and neck, with neurologists, but less with neurosurgeons. I must ask the Dr. John Washington, why not? I say I don't see any tumor boards in neurosurgeons because they have tumor boards and they invite us to go there in head and neck and neurology subspecialties.
Okay, I would like to use this opportunity and invite you for our tumor boards. We have some tumor boards, and I see Dr. Amri is here. I want to say hello to Dr. Amri, and Dr. Amri usually participates in our tumor boards, and we use his help so much. So, okay, I think this is a start for our communication.
Surely. Also, we have communication with Dr. Amri in our tumor board.
So if you agree, we would also like to step front and join your tumor board from the side of imaging physics, and maybe this basically triangle can establish much easier this way.
Yeah, sure.
Yeah, we would also.
Thank you.
So, if there is any other points let us know about it. If not, we say goodbye to participants and finish panel number 2, and we go for a quick rest till 8 p.m. Tehran time, and we start the third panel at that time. there is no other points to share with the participants, Dr. Janbakhshi, we finish this. Thank you. Thank you, everybody. The panel basically focused on prognosis for glioma tumors. In this panel, we will have an interesting discussion among four basically persons talking about glioma from the aspect of prognosis. Our neuro-oncologist, Dr. Ahmad Ameri, our neuroradiologist, Dr. Mohammad Ali Kazemi, our MR physicist, Dr. Michael Bach. I think he will be not presenting on just the video, will be broadcasted. And the AI scientist, Dr. Daniel Abler. Here, I would like also to say special thanks to Daniel to help us organize this meeting very well, especially with Dr. Nejat and Ms. Salari from Afghan. So let us basically use the time and start with Dr. Ameri, neuro-oncologist, talking about glioma in imaging.
Thank you very much, Dr. Salihullah. Let me thank all executive committee for inviting me in this interesting webinar. At first, I have to say I'm Dr. Ameri, clinical oncologist in Shahid University of Medical Sciences. I treat patients with radiotherapy and systemic therapy, including chemotherapy and other targeted therapies. As you know, I'm a clinician. For me, it's very difficult to understand what the scientists like you say. We used to see and decide based on our observation and the result of the treatment. And the new modalities that you presented to us, you all scientists presented to us, is very helpful for us. But we need these modalities be approved in the clinic, usually in the randomized clinical trial, and then we can afford it to our patient and use it in our practice, our daily practice. I just remind the prognostic factor that we usually use clinically in our practice for our patient to define their prognosis and help them and response to their question about their prognosis. We can divide the prognostic factor for glioma to 4 categories. The first category would be the demographic and clinical factors that we usually obtain from physical examination of the patient and taking a history of the disease that usually back to several months before the presentation and even sometimes several years before presentation in the low-grade gliomas. Anatomic factors that we usually see in the imaging, including CT scan, MRI, that MRI has a very important role. And the other group is histological factors that define in tumor specimen by the pathologist. And nowadays, the molecular that has the special place in defining the prognosis of patients. And usually, we obtain this information from the tumor or blood sample. Regarding demographic and clinical factors, the gender is a factor that used sometimes for defining the patient prognosis. Also, there is lots of controversy about the effect of gender for this, for the prognosis of the patient with gliomas, including low-grade gliomas and high-grade gliomas. But it has been used in the web-based tools to define patient prognostic factors. But when we change the gender in this calculator, you see that the differences that results is very small. But age is the most important prognostic factor and the strongest prognostic factor from years, many years ago, and it was the most important prognostic factor, and still in the 2020, it's again the most prognostic factor, and the WHO new classification divided patient based on age into adult gliomas and pediatric gliomas. It means that the age is the first prognostic factor we attend in the clinic when a patient come to us with over 70 years old. We would be worried about the results of treatment. This factor is a continuous variable, and when the patient get older, the prognosis would be worse. In low-grade glioma, also the age has a prognostic value to define our treatments. Is there any intervention indicated or no? It depends on the patient's age, and it affects the decision about he or she's treatment. Performance status of the patient is another factor that will define what treatment and what kind of treatment we can offer to these patients. A patient that is bedridden, there is no need for more information, and this patient needs just palliation, and we don't offer any more treatment to it, especially when the imaging show us probability of the high-grade glioma. Symptoms as presentation, especially in low-grade glioma, can also affect our decision about the patient intervention. If the patient has focal neurological symptoms, we are worried about the symptoms and try to relieve these symptoms. But when the patient just has seizure and no focal symptom, and the seizure could be controlled with the medication, and patient would be stable for several years. Anatomical factors, as I told, we usually use MRI, routine MRI, including T1 weighted, T2 weighted FLAIR, and somehow about diffusion weighted MRI. We don't know more than this, and we usually should decide based on this series, and more complicated series and sequences is not useful for me as a clinician. And if I want to use this kind of the information, I have to invite some other radiologists or some MRI physicists to help us define more information from these images. In the routine MRI, we usually focus on the location of the tumor. Deeply located has a worse prognosis, especially when the tumor is located in around the ventricle and we are subventricular area. We would be more worried about the result of the treatment and the propagation of the tumor in this area. If tumor is supratentorial or infraterminal, may affect the treatment results and may affect the patient prognosis. Number of lesions, also this another factor that we extract from the MRI, and the satellite lesions show us some worse prognosis. Located tumor in the eloquent part involvement also give us some information that the outcomes of patient after the treatment would be challenging, and the patient should have know what happened after the treatment. Tumors that crossing the midline is very, very important for us because it affects both hemispheres of the brain, and defining the treatment approach for this kind of patient is more difficult, and usually the recurrence rate is more prevalent. Midline tumors usually is seen in the pediatric gliomas, but with the new definition and with molecular classification, midline tumors also may affect adult patients, and these have usually poor prognosis and with some special marker in the molecular studies. The border of the tumor is another factor we tend to focus on it for defining the patient's prognosis. More defined border and more clear border show us that the tumor would be completely resectable, but if the border is infiltrative, completization is less probable, and we are worried about the volume of target that we define for the radiation therapy after the surgery. Histological factors that affect the patient prognosis has been defined long times before, from pilocytic astrocytoma until the GBM, based on the WHO grade 1 to 4 that has changed in the new WHO classification of brain tumors. But we know all about this. We have several GBM and pilocytic astrocytoma low-grade MRI, and we like to know about this classification. New classification is very difficult for us at present time to be familiar with it for deciding about our patients. KIHSF that show us the proliferation of tumor is also a prognostic factors, but it had not been approved in the multivariate analysis, and its independency has not been approved. Microvasculature, that's a marker that usually we can assess by the new MRI technologies like as perfusions, is another factors that we can attend to this when we are discussing patient about the prognosis and about the results of the treatment. Necrosis, that is especially in the previous definition of the glioblastoma, is essential for the glioblastoma. Also has some prognostic value. Several studies try to bring together some clinical variables and define the patient prognostic and define their overall survival. And one of them I've told before is for cancer that I found recently in the web, and it's based on two studies from RTOG, two phase 3 study of RTOG 0, 5 to 5. That is the randomized trial that entered the patient for chemoradiation with temozolomide or just radiation. And the second one study, RTOG 825, is the study that compared standard chemoradiation with temozolomide with the chemoradiation plus bevacizumab. The data from these two studies came together and calculator developed that variables are age, gender, performance of the patient, resection time, including complete resection or partial resection, and also MGMT methylation, that's the new factors. You can find it as I bring here the URL. You can use it on web. Another tools that you use for GBM in the clinical trials for defining patient prognosis and stratifying patient based on the prognosis is recursive partitioning analysis that have changed several times, but the recent one have 3 classes, class 3, 4, and 5. Some classes came together and make just one classes. And they can predict the patient overall survival when we define the trials. Stratification patients based on these factors may help us to reach a better understanding of the result of intervention. And also some similar study and analysis have been done for patients more than 70 years old. But molecular is the nowadays principle of classification since 2060, when you change from clinical pathology to a combination of clinical pathology and molecular studies. But in WHO new 2021 classification that came out 3 days ago, I think, classification of brain tumors divided in the adult type and pediatric types. As I've told before, the age is important things from the starting of knowing the glioma until now, and classification is almost completely based on the molecular criteria. Even grading is based on the molecular analysis. The most important changes that have been happening in the WHO 2021 classification for our clinicians is that there is no GBMs with IDH mutant tumors. So if we detect the IDH mutation by IHC or other PCRs or our sequencing or other tools, this is not GBM. But in the 2060, we have GBM, IDH mutant type, and IDH wild type. In new classification, there is no GBM with IDH mutations. Also, there are some astrocytic tumors, diffuse astrocytic tumors, that are IDH wild type and have some special genetical alteration. They also classified as GBM without necrosis, without other morphological findings of the GBM. About the diffuse astrocytic tumors, we don't have anaplastic astrocytoma. We just have one term as the IDH mutant diffuse astrocytic tumors. And this is a single entity, and its name is astrocytoma IDH mutant. Grading has been done, but most of them are based on some genetical factor. One of them I bring here. Thank you very much. I told something about our decision in clinic. We just know this parameter that I mentioned in my slides. More than this information would be complicated. This information, if we want to use in clinic, have to be simplified and entered to the studies, entered to some clinical studies, and we can use them for our patients. Thank you very much.
So thank you so much, dear Dr. Ameri, for your excellent presentation and the information you shared with us. Right now, I move to Dr. Kazemi, the neuroradiologist, basically talking about the prognosis of this problem in glioma imaging. Okay.
Thank you again, Dr. Sarupa, for as we are going to talk about prognosis and what imaging can do about the prognosis. As you mentioned and you discussed about the advanced imaging, advanced imaging really helps us about the prognosis. First, we want to know about the cellularity of the glioma. When we know that more than 70% of low-grade, grade 2 glioma, the progress to advanced high-grade glioma, anaplastic, and then GBM, we must know which one is more prone to progress. And we must know about the cellularity, and what helps us about the cellularity. The best is diffusion imaging, and we use the ADC maps. As we know, the low-grade glioma don't restrict, and we are not prone to restrict. But if we see restriction, we must be aware of progress into high-grade glioma. The second issue is angiogenesis inside the tumor, and the best modality which helps us is the dynamic susceptibility contrast enhancement to show us about the relative cerebral blood volume. And as you mentioned about the 1.75, many articles have mentioned it and focused on it. And it needs much more evaluation. Some patients show allergy to contrast enhancement, and we can move to arterial spin labeling. Arterial spin labeling has more shows more artifacts, and it's a little more problematic, but so feasible, and we can focus on it and do it for many tumors. Then how much we have more RCB, we will have worse prognosis. Then we can know about the capillary permeability by diffusion contrast enhancement. Also, they have used much less than dynamic susceptibility contrast enhancement for glioma, but it is really feasible if we use caterons, and the more caterons shows the worse prognosis. Also, we need to know about the mitotic activity of the lesion, and here, as we all know, MRS can help us. They have shown that the ratio of choline to keratin more than 2.4 is relatively specific for high-grade glioma. And as Dr. Mri and our pathologist talks about the IDH mutant types, here we can go to MRS and measure 2Hg. 2Hg is in many articles they have said it's 100 sensitive and specific for IDH mutant types of glioma. Is not accepted nowadays to replace the pathology, but more researchers can confirm it to research to have much more role in evaluation of the prognosis. These are the modalities that may help us to have better prognosis. And as the conventional, we know that increase in size that we talked about how to measure, and how the AI can help us to measure the progression in size and also enhancement. adding the enhancement to the tumor shows the progression of the mass. We don't have enhancement in grade 2 and some types of grade 3 astrocytoma. But we must know that relative cerebral blood volume shows the progression about 6 months to 1 year before enhancement, before when enhancement happens, and it's really helpful for us. Thank you very much.
So thanks a lot, Dr. Kazemi, for your explanation. It's very useful. Before basically broadcasting Dr. Michael Bach presentation, he's unfortunately absent and not present at the meeting. He's basically the MR physicist who is supposed to cover this part. But before broadcasting this, I would like to thank all the participants joining us to the end of the program. Also say hello to Professor Sultanianzadeh, or basically the pioneer in the field, and thank him to join us for tonight. So I ask Dr. Nejat to broadcast Dr. Bach's presentation, which is now.
Thank you very much for the invitation to this webinar. My name is Michael Bach. I'm a physicist at the University Hospital of Basel. For several years, I'm focused on MRI quality assurance, quantitative imaging, and standardization. Unfortunately, I cannot join this seminar live, and I will not be available at the discussion part. However, please do not hesitate to contact me via email in case of any questions. Quality assurance and quantitative imaging are connected to each other because as soon as pixel values are used as quantitative measure, there is a need for evidence that the measured values are reliable. For a scale, it is checked by a test weight if the measured weight is correct. In MRI, we use phantoms instead of test weights, but the idea is exactly the same. Since the range of applications for MRI is much broader, there are a large number of phantoms. The first example of an MRI phantom is the phantom of the American College of Radiology, which is shown here. And these are the test images which are created by an MRI acquisition. The phantom contains exactly defined structures, and the imaging device is tested by checking how well it can reproduce the well-known structures of the phantom. For example, it is checked if the nominal resolution is really achieved in the measurement, and if the known length of the phantom is imaged correctly, and how good objects of low contrast can be detected, and so on. These are some very basic, nevertheless important tests to trust the MRI machine. We use the ACR phantom for regular quality assurance measurements and have developed a tool for the automatic analysis of phantom images and creation of quality assurance report. So we simply upload the acquired images to our tool and get this report back, where we can see if all the tests are passed or if there are any problems with the machine. For diffusion or relaxation time measurements, a typical phantom would consist of different compartments with different ADC or relaxation time values. Here you can see a T2 weighted image of a phantom with different ADC compartments. Here the B1000 image and here the corresponding ADC map. Different ADC values are realized by the use of a water-soluble polymer called polyvinylpyrrolidone. The higher its concentration, the lower the ADC value. The last time I used this phantom was because I am responsible for a new 0.5 Tesla low-field MRI, and I wanted to check if this machine measures the same ADC values as our 1.5 or 3 Tesla machines. Fortunately it did, because in fact the ADC value should not depend on the field strength. For the test of mapping the relaxation times T1, T2 and T2 star, the phantom design is the same, different compartments with different solutions to realize different relaxation times. Here you can see one example of the impressive fiber tracking images of the human brain. To obtain these images, one measures the main diffusion direction in each voxel, because the diffusion, the movement of the water molecules, takes place easier along the nerve fibers than perpendicular to them. The main diffusion direction corresponds to the direction of the fiber bundle. Fiber tracking algorithms are then able to reconstruct the path of the nerve bundles, and the result is shown here for one cerebral hemisphere. Potential questions are: what are the typical limitations of a specific fiber tracking algorithm, or how well are fiber crossings reconstructed? Phantoms with areas of anisotropic diffusion can help to answer such questions. This phantom consists of a spherical spindle, and on the spindle wet polyester fibers are wound. The resulting fiber strand show an anisotropic diffusion like the fibers in the brain. But in the phantom, we know the exact strand dimension and diffusion parameters like the fractional anisotropy or the mean diffusion. I have now presented some phantoms and how these phantoms make it possible to check whether the MRI provides the correct quantitative values. In the remaining minutes, I would now like to discuss the fact that the correct quantitative values are not at all as unambiguous as one could assume, or more precisely, that the measured values depend on the exact parameters of the measurement itself. Shown here are the measurements of the ADC in the peripheral zone of the prostate and the prostate cyst. The same subject was examined at 7 different centers, and the box plots here show the variations between the centers in the measured ADC values. At each center, a 1.5 Tesla and a 3 Tesla machine was tested, but more important, 2 different diffusion sequences were used. One was the in-house sequence used in daily practice, and the other was a standardized sequence. And in the standardized sequence, care was taken to ensure that the acquisition parameters were as similar as possible for all centers. It can be seen that the variations in the measured IDC values across the different centers are significantly reduced for the standardized protocol. When no care is taken to standardize the sequence and every center uses their own protocol, the fluctuations are significantly larger, as can be seen in the values for the in-house protocol. The reason in this case was mainly due to the use of different B values. Different B values in combination with perfusion effects can introduce quite large variations in the ADC values. Also, for the quantitative imaging of relaxation times, it is important to standardize the acquisition technique. T2 maps, for example, can be created by multi-echo, spin-echo, or turbo-spin-echo sequences. Depending on the tissue, different acquisition techniques will yield different values for the relaxation times. So in order to obtain comparable quantitative pixel values, it is important to standardize the acquisition protocol. If one wants to compare their own quantitative values with the values published in literature, it always has to be checked if comparable acquisition protocols were used. In summary, MRI quality assurance, quantitative imaging, and standardization are connected to each other. To trust the values obtained by quantitative imaging, phantoms of well-known properties can be used to check if the MRI is able to measure the expected values. The expected values in general depend on the acquisition scheme. Therefore, a standardized image acquisition is necessary to obtain comparable results. Thank you for your attention, and I want to apologize again for not being able to join this webinar in person. If any questions occurred during my presentation, please feel free to contact me via email.
Special thanks to Dr. Michael Bach, and I would like to continue my regards also to him via Daniel. We're talking about QC and standardization for multi-center imaging in this paradigm of basically tumor imaging, especially when we use advanced imaging, is greatly important. So I was really happy that he covered this topic, which was very, very important for us, and maybe not other people basically covered this, and I'm really glad that he chose this topic and covered this for us. A special thanks to him. Daniel, please convey our best regards to him. I will, of course, thank him via email later. Here I welcome Daniel to cover the AI part, partner to Professor Muller's group, are very to you to help us organize this meeting, and thank you for your cooperation. We do not have your voice, Daniel. Your voice is not there.
Hello? Hello? Okay, I'm very sorry. I hope it works now. So apologies. Excellent. Yeah, I would like to give a perspective on image-based glioma modeling for prognosis. Now, there's a huge literature out there. Therefore, I would like to define the scope a little bit. And essentially, I'd like to focus on finding imaging biomarkers, which means some measurable characteristic that can serve as an indicator. And here we are looking for an indicator of disease outcome, regardless of the treatment, so for prognostic biomarker. And as we've seen before, there are many existing biomarkers, for example, those molecular biomarkers for glioma that I'm listing here. And as you can see, there's always some overlap between whether they have a diagnostic, a prognostic, or also a predictive value. And to limit this a little bit further, I would like to focus on image-based modeling that looks at direct correlations between imaging features and survival or recurrence. So not at studies that try to predict, for example, another molecular biomarker, which would also be predictive in that sense. And now we have already covered most of those. So once you have the image, of course, you can derive features from those. And these can be based on morphological characteristics or so-called semantic features. These are features that neuroradiologists would be typically using. And also Dr. V, Professor Wies had mentioned them in the morning. Those are also features that are already used as predictive features in the clinical practice, as we've heard just now in the session. Then there is a group of that I call functional features. These are features that may be derived from functional imaging. Now they share the commonality that typically there's they are well interpretable because they are closely aligned to some biological or physical processes, or they allow to derive information about those. And finally, there's a large group of features that is often utilized in what is called radiomics. And those are features that are not typically used by radiologists, but they do try to capture heterogeneity in a given region of interest in a quantitative way, by using mathematical descriptors of this heterogeneity. And as we will see, this is very commonly used in those radiomic studies. Now, the standard pipeline, the standard process for many machine learning based prediction models is depicted here. And typically, well, we start with a data set, and from this data set, typically there's the need to define a region of interest where we expect salient features to be present. From this region of interest, we then extract a number of features. These can be any of the features that I've mentioned before. And potentially this can result in an extremely large number of features, not all of which are readily interpretable. Therefore, a very important step here is to essentially boil down this high number of features to a set that is relevant for the specific modeling purpose at hand. So if we speak about survival, for survival prediction, this is often called feature selection and is sometimes combined with a model training step in which you test the influence of a feature on the resulting model. Finally, there should be, of course, an evaluation of this model, and this is best performed on a separate data set, as we also heard today in the very first session. Now I would like to show you two examples of prognostic modeling studies that follow this scheme, and to give you an impression of what exists and how those studies are typically built. So this is one study from the Netherlands. They have two data sets, a training data set that is purely used for model building, as it should be, and a validation set that is used in the end to evaluate the feature, the model. They define two regions of interest based on the enhancing tumor and the hyperintense region on T2 or flare. and extract two types of features. One's the Vasari features. These are these semantic features that are commonly used, and a very large set of agnostic features, which are typical radiomics features. Then, as you can see, we have a very large number of those features, 1,200, so those are being reduced. And eventually, the resulting model, which is based on a multivariate Cox regression, which is very typical for survival problems, is evaluated on the data set that has not been seen in the training process, the validation data sets. So there are a few things I would like to point out. So on the right in the table, you can see in the bottom part of the table, you can see a set of features. Now, in the top part of the table, you can see the set of Vasari features that has been selected by this model. And you will recognize some common features that are known to correlate to be prognostic to outcome. On the bottom, on the bottom part of the table, you see a number of features that have been selected from the agnostic features. And well, what we know here is that they are mostly features derived from T2, but their specific interpretation is very difficult. Some of those characteristics tend to be associated to heterogeneity within a compartment, but it's difficult to really pinpoint a precise meaning. On the bottom, you see a performance evaluation of different combinations of models, comparing in blue the performance on the training data, on the training set, and in red, the performance on the final validation set that has not been involved in training. And what you can see here is that both those Vasari features, the semantic features, and the agnostic features separately have a worse performance than when both features are combined. I'm sorry, there's no box. And if you compare the performance of the clinical features alone with the imaging features alone, then the performance improves substantially at the very right when you combine all imaging and clinical features together, and also the model appears to become more robust. So here they included very well interpretable features in the model. I would like to present another example where the model is entirely based off agnostic features. In this case, they've generated for each region of interest over 3,000 features, so a huge number. And again, after a selection process, they derive a model that is predictive, prognostic in this case, for outcome. And on the table on the right, you can see the concordance index, again, a measure of performance. So 0.5 corresponds to random, 1 corresponds to perfect performance. And as you can see, the radiomic features alone have values between 0.67 to 0.8. Combined with clinical features, this value improves drastically. Now, in order to add some interpretability to those features, what they did here is they tried to compare the parameter maps of the apparently most important features to underlying pathological characteristics, and they found correlations there that indicate a relationship between one of those features to underlying pathology. However, this is still a small study with only 30 training cases, so it's difficult to generalize from this at that point. So after those two examples, I would like to give you a quick overview of the status, very specifically prognostic modeling for survival in glioma and mostly glioblastoma. On the right, you can see performance metrics. As we've seen before, the C-index, the concordance index, is in the range of 0.7 and a little bit higher. On the left, I included information from recent reviews of such studies. And well, what you see there is that the studies are very heterogeneous. So the outcomes, the way the outcomes were included in the model are different, which makes the comparison of the performance results different. And also from 27 models, only 7 did a validation in a retrospective validation in the separate data set. So this means that many of the performances indicated here are probably overestimating the model performance. Overall, those models work with up to 200 data sets. And much less when we are talking about predictive models based on functional or quantitative MR imaging. So as a summary, I think there are, so I gave some promising examples, let's say, that show that combining semantic and agnostic features improves the prognostic performance of those models. So, and also the combined performance of imaging features and clinical features appears to outperform the performance of clinical features alone in those models. However, well, there are many challenges here. This is an evolving field. And one of the big challenges is the availability of data. We've touched upon this today already. And as a result of this, there are, for once, there are very few deep learning studies that require a lot of data. And also there, in fact, are very few such modeling studies on low-grade glioma because there's less data, public data available compared to glioblastoma. And again, related to the shortage of data is the challenge of how generalizable, how transferable those models are. So none of those models is currently used in clinical practice, is prospectively validated. And this can only be achieved with a larger training data set. Finally, a big role here is what the talk of Michael Bach just touched upon, is the need for standardization. But not only for standardization for with regard to anatomical imaging and to have similar appearance of edges, for example. But if we talk about those radiomic features, we would also need to have phantoms for texture features, for example, for MR texture features. Lastly, there's the question of interpretability. Now, clearly using functional features or easily explainable semantic features helps here. But if we want to explore more complex relations between imaging and complex predictors based on features that are not visible to the human eye, we need to keep in mind to make this link to the underlying physiology and biology. So that is it from my part. I thank you for your attention,
so much.
And I'm looking forward to discussing. Hello?
I really enjoyed it.
Yes, hello.
Thank you very much. And I think you are the moderator of the discussion. So I also urge everybody to come to question and answer and ask questions, but you are basically the boss, the moderator, so please.
Okay, yeah, thank you. So I mean, of course, I would like to invite the other panelists to question me as well, but I would have a first question for Dr. Kasemi, and you mentioned many very promising prognostic imaging biomarkers and how you would use them in clinical practice. And I was wondering, where do you see gaps in what is currently available? I mean, what are the things you would like to have better prognostic information about, and where you see they are not achievable with functional or anatomical or quantitative imaging?
I think I'm on there. Yeah. You have my voice, yeah. Yes. Yes.
Hello. Yes, I can hear you. I can hear you, Dr. Mri.
I think if we want to be accurate and really well delineate the lesion, we must move to quantitative imaging, and really quantitative imaging needs physicists besides us. Physicists are so helpful in quantitative imaging. Yes, we can have all of these imaging on our machines, and we can have our data, but when we need voxel by voxel evaluation, we need segmentation of the tumor, not totally evaluate the tumor. We need segmentation, and that's the need for having good physicists beside us, and they are so helpful. And at the next step, when we want to gather our data, we have many data together, but we don't know how to best decide with them. I think that that's when radiomics and artificial intelligence surely will help in future and near future. Thank you.
Yeah, thank you. Yeah, I mean, I certainly agree on that. There's, I think, interpretable information on a voxel by voxel basis is probably the best you can get. And then, as you say, there is a challenge of integrating this information into decision models. And this is then probably a question of modeling, and either of statistical modeling or of mechanistic modeling, or of a combination of both of those. Dr. Ameri, you mentioned this a prognostic tool based on clinical risk factors. Could you imagine something similar that takes clinical risk factors plus the set of images that is provided, that is available from clinical routine, or maybe, yeah, let's say from clinical routine? What would need to be the characteristics of such a tool so that you would feel comfortable?
Thank you for your nice presentation.
You would base decisions on it.
I think we need to approve any prognostic factor in clinic. As you mentioned in your talk, the numbers of image that has been analyzed is very small regarding in comparison with the clinical data that was be validated based on, for example, the web-based tool that I mentioned in my talk is based on 2 large randomized trial data. the age is age. The performance has very well-defined score. And maybe MGMT has been well-defined and well set up and has their own standardizations. And all of them has been done in the reference centers. And so we can rely on it. We know every modalities, every analysis had some pitfalls from the start until the end. And we as a clinician, we always worry about this as shortcomings. If these imaging factors want to be in the clinic for using in clinic, I think we have to have large data from standardized imagings. We see every day. We send our patients for different imaging centers, and we saw the difference between the centers. That's the smallest things that we can recognize. We have to know there is a lot of things that's not appear in the image. We can how we can trust on this data. You know, I love to put my responsibility on something like this radiomics, radiogenomics, other things. But we need more data with more validated and more standardized data. That's why if this data be available, we like share our responsibility with others. But nowadays we have to decide by own. We sometimes we have problem with the reporting of the MRI. Some non-expert radiologists, we don't have any problem with Dr. Cousin. We're working with each other and we know what we have, what we want from each other. But when accidentally our patient go to a center that we don't know where report the radiology, where they acquire the imaging, we have a problem in clinic. We have to decide. We cannot send the patient for the imaging. That's it. If this we do a study on the IDH mutations with the MRI, we use the Canadian data. And because we couldn't find good and standardized imaging in Iran, Dr. Saleh knows making a standardized center has a very difficulties, at least for us. We do we acquired about 20 image for parotid before radiotherapy, after radiotherapy, to use it to predict using ADC to predict xerostomia after radiation. We do one before radiotherapy, one weeks after starting of radiotherapy, and one after 2 months after the radiotherapy finished. We couldn't use the data. We do a standardization before the work, but we couldn't use the data for the validation for the reporting. That's our problem. We need simplest things that we could trust on it based on a big data.
Yeah. 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 So I fully agree with you that what I presented, and I think I made it clear that this is really in the research domain. What I'm wondering always is, so suppose you do the study and on a very large data set you find very convincing that some feature that you can't explain biologically or physiologically has a significant correlation with your outcome of interest. It's statistically very convincing, it's well done, but you can't explain it. How would you accept it or not?
Yes. If we want to accept
from a clinical perspective
100%, we need randomized clinical trials for any intervention. For example, if you acquire the MRI from low-grade gliomas, we don't have any needs, as I know. We don't need anything in the high-grade glioma for GBM. They usually have symptoms. They usually need the treatment. We acquire the sample for the decision in this time. But about low-grade glioma, we have lots of shortcomings that imaging could help us to decide better and better. For example, as Dr. Kazemi told, some people with low-grade glioma, the differentiated will be differentiated to the high-grade gliomas. If we could define these patients with non-invasive measure, it would be very useful for us, especially when approved in a large prospective trials.
Yeah.
Actually, we use it, yes. But for example, if patients should be do MRI, and based on MRI, for example, we know the IDH mutations, for example, yes, then we decide with this information, decide about patients' treatment. And after the treatment, we compare the result. We compare the result. If the result is as same as the clinical decision before MRI or better than this, it would be a valuable index for us to use in clinic. But as I told you before, we have lots of problems about the quality, about the acquisition, about the reporting, about everything. We know there are a lot of indexes and sequences and other things that we can differentiate between, for example, radiation necrosis and tumor progression. But I'm involved with this question every day, and very rarely I can achieve a convincing response, a good response to decide based on. Actually, at the end, I decide based on my clinics, patients' symptoms, and follow-up imagings. It's very difficult for us to decide. This kind of problem in clinic is our day-to-day problems. I don't know. I hope the study be propagated more and more, and we saw more studies, valuable studies. But I think that there are no sponsors for MRI. And the studies need money. Nobody support, no company support the studies in imaging, as we have problem with radiotherapy also, but we don't have any problem with the drug. All companies support the drugs, and several studies would be held by the money of the companies, drug companies. We know nowadays there is some relation between radiation and response to the immunotherapy drugs. And the radiotherapy studies jumped again because of the drug companies are interested to this kind of the studies. You have find something like this. If you can target some drugs, maybe the study will expand and more and more. Yeah.
Okay, thank you. I would love to continue this discussion, but I think we are already quite a bit over time. So I'm not sure if it's me who is closing the session, but preemptively, I would really like to thank the other speakers.
Thank you very much.
For the
Thanks, everybody.
Thank you very much.
Yeah, hand over.
Yeah.
Thanks, Dr. Amari. Thanks, everybody.
Thank you very much. Good night.
Thanks, Daniel.